Hi, and welcome to the show. Subscribe at kevinmu.com/podcast. Today, we welcome back Kathleen Muldoon, coach and professor. Today's Kevin MD article is The Humanity We Bring, a call to hold space in medicine. Kathleen, welcome back to the show.
Hi, Kevin. Thanks for having me.
All right. Tell us the story of this latest article.
Well, this article came to be actually as a response to I won the 2003 Northrop Educator of the Year Award from the Student Osteopathic Medical Association. And it's a national award, and it was such a big deal, a highlight of my career. And I was invited to write sort of an acceptance speech or a response to it. And I just got such a nice response back from what I said that I wanted to make it available to your readers, your clinicians, your students who follow your space, because, what I was struck by in their nomination letter and in the things they said about me is that, the reason why I won this award wasn't because I teach embryology really well, which I think I do, or I know a lot of anatomy, which I think I do, but it's more holding the space for authenticity and humanity and modeling that, but also trying to teach that in various ways to our clinicians, initially in the classroom, and now I do it from the coaching corner as well, that who you are is not something that you need to check at the door of the clinic or leave behind when you experience the white coat ceremony, but it's something that I think medicine really needs right now in creating a culture of caring. And so this piece kind of came from the fact that, some people do think that humanity in medicine is something that you have to hide, or that it's soft or anti-science even, but I really think it's structural. And I think we need to think of it as the foundation of moving this field forward.
And the genesis of this article came from your own personal experience, right? So let's start there. Tell us about the story that kind of led to this.
Well, the story that I began the piece with, and I think was really a Damascus moment for me and thinking about who I am in this space, was when my middle child was born. So his name is Gideon, and it was a textbook pregnancy. And when he was born, about 18 hours after birth, he was whisked away from me to the NICU, where eventually he was diagnosed with a congenital cytomegalovirus infection. But up to that point, I had already been an award-winning embryology professor at an Ivy League school. And it was really the first time, especially in those wee hours of the morning when my son was sleeping and I wasn't, and I was sitting in the chair next to his cribette, and I would just kind of walk the floor and see all of these tiny people with the diagnoses that I had been teaching. And I think a lot of people teach embryology this way, where it's the, like the blue box is what we tend to think of it in the textbooks. This is how the story is supposed to go, and this is how it goes. And I hate to use this, but when it goes wrong or when it's interrupted, and I don't use those words anymore. And I realized, I would see the words that had just been on the page and that are on the page for a lot of students. And I think that it's very easy in practice to slip into seeing people as diagnoses, right? And not understand that these are real live humans. And now that prenatal care is so great that you can even think about that there's a whole type of way of being a human, a disabled human, right? That is chronic and long-term and isn't cured, right? Which I think is a promise that some people feel kind of called to, or what they think medicine is like. Especially I see students come in all full of, hope of this, their definition of helping somebody, and the power of that is curative, right? But there are so many conditions. All of life is a chronic condition, you could say, right? And learning how to partner with your patients in that uncertainty. And for me in my own life in that moment, I realized, it was actually when my daughter came, who was about 3 years old at the time, for the first time to the NICU. And, I was all prepared to apologize for her experience of becoming a sister. And I didn't know what it was going to be like. And she slipped into the armchair next to me, and she gingerly maneuvered around all of Gideon's sensors. And she looked at me and she was like, "Mom, isn't he perfect? He has a head." and like that kind of childlike wonder. And I was like, he is perfect. He is here exactly how he is. I don't know what the future is going to hold. Actually, his pediatrician came to the NICU and just sat with me for several hours. And that was everything. Just being present, not offering any solutions, not offering, there were some treatments, but understanding that being present to the situation and just that partnership was actually the best and most healing moment for me.
Now, that story, of course, was very powerful. And that concept of holding space, being present, that's not often taught in a formal way during medical training, is it?
Not in my experience, unless you have purposely made space for it, right? Often, even in the less traditional medical school curricula, there are just a lot of, ANOVA tables or practicing scripts with standardized patients, So I've been lucky that I've been allowed to have some time in the curriculum, in the core curriculum at our school, to inject what I think needs to be a workshop, a discussion, right? Really sitting in those uncomfortable spaces with things that are not solvable.
Yeah.
And so we do it through kind of a series of courses that I teach that really kind of force us to examine unsolvable, at least by any individual, current challenges in medicine, right? So health disparities, disability features large in the course, and students they always want to jump to, well, what's the solution?
Yeah.
Right? What, and I always say, like, the offer, well, we should have a policy against this. We should be doing this. And I have to tell them, stop shooting on yourself, because that's the number one thing to kind of distance a problem, is just to say, well, we're going to have a policy for that. But I've seen more often than not, some legislation put into practice or a policy that just distances the problem. But how do you sit with it, right? And, we're in Arizona, in a classic situation I like to present. You can present it as a case, you can present it as just looking at data. And so, for example, like, someone who lives up north in Arizona on the Navajo or Dene reservations come down with like an A1C that's incredibly high, like 13, right? Does that mean that they don't know how to control their diabetes? Or does it mean that there's one doctor for every 100,000 people up in their area, and they made it down the 4 hours to Phoenix, where we're located, to get care? Like, how do you partner with that person and understand their story and understand that there isn't an easy treatment in that situation? And so holding space for that, experiencing what I think is the greatest thing then is to experience that discomfort and that challenge, because it does feel like a challenge. And instead of saying, well, they should be better about their care, what if they can't? And how do we walk to the edges of what's possible with our patients, with our colleagues, with our peer students, and see what is possible? And a lot of times that is healing in and of itself.
So that last statement that you just said, just holding space, being comfortable with a problem that may not be solvable, that in itself can have a huge impact on patients and their families, even if the clinician can't come to an immediate solution.
I believe so, and I can speak to that as a caregiver myself, and from my community of disabled individuals and their caregivers, that having someone who, even if they can't fully understand your situation, can understand that there's a challenge, taking that moment to just pause and say, like, this must be hard for you. What does this mean for you? And accept that you may be bringing into that clinical encounter your own experience with something that is difficult, right? And so the reason why I sometimes share these stories, and especially stories from my experience in the NICU, is not to generate sympathy, right? Because sympathy is taking on the emotions of somebody else, and I don't need somebody to put their opinions on my life onto me, right? But can you use that to connect with some other time that you've been worried about the health of somebody that you love, or your own child, right? And even if it's something minor, we've all been there, but can you connect with me in that moment? So bring a little bit of yourself into that encounter and help me to be seen, but also help you to understand that caring is part of the core science of being a doctor.
Hmm.
And you have to be who you are in order to do that. So I think holding space allows not only the patient to feel heard, but also the physician to reconnect with their own humanity. And I think taking that into every clinical encounter, I think will do a world of good to some of the challenges that medicine is facing right now, like burnout,
Hmm.
like, overwork, all of the things that I see from my position as a coach also.
Now, you mentioned that you had some workshops, you influenced the core curriculum to include facets of what we're talking about.
Yeah.
How do you train medical students to hold space? What are some exercises? What are some things that you do?
So I have a series of courses that I offer that begin with a course that's called Humanity in Medicine. And in that course, it's for first year students. We look at data illustrating health disparities and the value in doing that, very intentional in creating small group spaces for that are facilitated by upper year medical students and some faculty, is understanding that everybody's going to interpret that data a little bit different
Hmm.
through their lens, right? So what does it mean that there are disparities in vehicle ownership, and what does that have to do at all with medicine? Well, I mean, it does, right? Access to care. Not everybody of every socioeconomic status is going to have access to transportation. That's going to affect how they show up to the clinic, and these are divided a lot of times along racial and ethnic lines as well. And so having them practice that ability not only of interpreting the data, but also hearing other people's interpretations of the data and how they bring themselves into it, I think is really powerful. Students who want to continue in that skill and being able to hold those conversations and hear other people's reactions to the data, I offer kind of a training series of courses that I call the Gold Series for kind of humanity in medicine and humanism in medicine. And that includes a medical improv workshop
Hmm.
where we do exercises. These exercises were developed to create presence and empathy and being with each other. And sometimes they're called theater games, but we don't do any performances. It's
Yeah.
really accepting ideas that come to you, accepting your own reactions, and responding to usually just a partner in unscripted ways, and knowing that it's okay to make mistakes in these low key environments because you're trying. And there's
Yeah.
very much a difference between making a mistake because you're trying versus not being prepared and not accepting what is in front of you. So we do that. I also offer a narrative medicine course where we not only read poetry and other pieces to, again, kind of elicit that response in yourself. I love poetry. It's like an invitation,
Hmm.
right? And lots of people see things differently. And then writing your own piece, basically in practice also for being able to write your own personal statement, for example, for residency applications, because I see so many students that don't know how to do that anymore. And I
Yeah.
really feel like if you don't know how to write your own statement, if you hand it over to AI, or worse, I've even been offered money to write other people's statements for them.
Wow.
I mean, you're going to end up somewhere that's not a good fit for you. And I know there's a lot of stress on the match and on making it into the specialty that you had your heart set on for so long. But if it's not a good fit, it's, I think you're setting yourself up for a career of heartache. So that's kind of the series. Students often come back to help facilitate the first year course. And I think it works really well in creating a community of care. And I've been so grateful, as was indicated by the award that I got, but also students that have gone out now into residency after this training, and they're creating these circles of caring in their own placements. And I just think that to me is that grassroots effort of seeing the future that I think takes those parts of medicine that are so wonderful and just grows them in lots of different places.
So it sounds like a lot to me that we're asking students today to share a little bit about themselves, to hold that space, to be vulnerable, right? To
Mm-hmm.
express their own vulnerability to their colleagues, to patients, to their families, of course. And up until this point, students really aren't trained to do that at all, right? They're in fact
Right.
trained to do the opposite of that. You're not
Yep.
supposed to show any vulnerability, right? So a little bit of a shift in mindset. It could be a little bit jarring for some students.
It really is. And there are some students that armor up and they don't feel comfortable doing it. And that's okay because we're planting seeds, and I understand this is a little bit of a pushback, but I truly do stand by the tenet that, every honest encounter is a moment of advocacy.
Mm-hmm.
And that can be, somebody, I mean, we see so much data that supports an understanding that having that, not coming in and totally disclosing your whole life, but allowing your patient stories to actually be a gift back to you instead of something to deal with. That shift, that understanding that it creates patients that are more satisfied with their care, that are more adherent or compliant, whatever word you'd like to use, that have better long-term outcomes. So if you're somebody that does truly care about improving the lives of your patients, which I think every student comes into this field wanting to do, and then the process of enculturation can cause them to abandon that part of themselves,
Mm-hmm.
right? But if you stick by it, if you work through the discomfort and understand, especially now, there are so many different kinds of people that come to medical school, and we need every single one of you
Mm-hmm.
to just. It is hard. It is uncomfortable. It's just as hard as learning all those biochem cycles,
Yeah.
right? And stick with it because I promise you it pays dividends in the end.
We're talking to Kathleen Muldoon, coach and professor. Today's Kevin MD article is The Humanity We Bring, a call to hold space in medicine. Kathleen, as always, let's end with some take-home messages that you want to leave with the Kevin MD audience.
I would just love to leave with this audience that an understanding that we can't always heal what's broken, and that includes in your patients, it includes parts of ourselves, it includes the systems that we're working in right now, but we can honor what's human. And I think if we remember that that's the why of medicine as a field of practice, our stories, our identities, our care, I think that's what makes and will keep medicine whole.
Kathleen, as always, thank you so much for sharing your story time and insight. Thanks again for coming back on the show.
I really appreciate your time. Thank you so much.